So the title of my presentation is Health Literacy as Tools to Promote Health Equity in the Context of COVID-19. I have no financial conflicts of interest to disclose, but I do need to tell everyone that our Center for Humanities and Ethics is partially supported by the Office of Minority Health and the Department of Health and Human Services as part of an award that's funded by the federal government. The contents of my presentation are mine and do not necessarily represent the official views or endorsement of the U.S. government, and there's a link that you can see there for more information. This is for continuing education credit. Any health providers may join. We have nursing continuing education, medical continuing education, social work continuing education, but you must register, and I've put the link again just in case that's helpful to you. If you haven't registered, you'll need to do so in order to get credit here. So the learning objectives for today are, first, we're going to compare and contrast the most recent definitions of personal and organizational health literacy. What is it? What is health literacy? What kinds of health literacy are there, and why should we care about it? I'll describe the link between low health literacy and poor health outcomes, including COVID-19 health outcomes in San Antonio, which we care a lot about. And then we'll look at health equity promoting tools within the layers of our health systems of care. And finally, we'll talk about how this entire 7-session series will help us develop proficiency in the first of 6 health communication skills. And we'll talk specifically today about using plain language, and with a nod to Martin Luther King, who said, of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. So the demographic context of San Antonio is important when we consider what health literacy is and why it's important to us in particular. We're a minority city, if you will, with at least 64% Hispanic population, 18% or so living at or below the poverty level. 1 in 5 people are uninsured, which is over 280,000 San Antonians as of last September 2020. And a quarter of the patients that I take care of within the university health system are actually unfunded. And quite a few of them are assisted by interpreters or translators. We have 14% foreign-born, and a third of our immigrant population is undocumented. And recently, San Antonio has resettled over 10,000 international refugees, and that continues. So all of these things are important. These demographics have implications for health literacy interventions. So let's get to those definitions. What are we really talking about? This is the definition of individual health literacy. And that is the degree to which individuals have the ability to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. And that's from the U.S. Healthy People 2030 Initiative. On an organizational level, it's really the same thing, but it implies that health delivering organizations are responsible to make this happen. So organizational health literacy is the degree to which organizations equitably enable individuals to find, understand, and use both information and services to inform health-related decisions and actions for themselves and others. And I'm underlining "and others" for just a moment, and you'll see why. What's important about these definitions? Well, first off, they emphasize people's ability to use health information rather than just understand it. This implies that just having a Spanish language interpreter working with a doctor doesn't necessarily mean that you've done the whole thing that you need to do for that patient. The information that's being communicated has to be information that's useful for that person. If you tell someone who lives in an urban jungle where the parks outside have broken injection drug user needles in them, telling them in their own language that they need to go use their park and exercise doesn't necessarily mean they're going to be able to do that. So it emphasizes people's ability not just to understand, but use the health information. Next, it focuses on people's ability to make well-informed decisions rather than appropriate ones. People may ultimately make decisions that aren't the ones we might hope they make, such as deciding to get a COVID vaccination, but at least we will have provided them with good information and an ability to distinguish good from bad information as they make those decisions. And then they incorporate a public health perspective. So it's not just about making decisions for themselves, but also making well-informed decisions for other people in their family and in their community. And they acknowledge that organizations like ours have a responsibility to address health literacy. And that's what we're doing together today and will do in the sessions that follow. So these definitions all indicate that people and organizations can use health literacy skills to improve the health of our communities and our members. How big is this issue? It's huge. It's not just huge in San Antonio or just because of the demographics of San Antonio. This is data from the United States and it's U.S. Department of Health and Human Services information from as far back as 2003. It turns out that 9 in 10 adults in this country have difficulty using everyday health information. And so someone who's proficient would be an individual who can look at their health benefits in their human resources information, and they can calculate what the employee's share of the health insurance cost is. That would be proficient. Real basic is being able to answer simple questions based on a clearly written health pamphlet, and that's what we want people to be able to do when they come to clinic, right? Most people are being asked to answer simple questions about their health, and it turns out that only about 22% are basic, and then below basic is, can you even circle the date of a medical appointment on a piece of paper that's been handed to you as you're leaving the clinic? And it turns out that we have about 14% below basic. So if you take basic and below basic, that's more than a third of our US population, our English-speaking US population, that have difficulty with that. So there's a lot of work to be done. And these issues need to be paid attention to because they clearly affect people's health outcomes. And I promised you that I would tell you about the link between low health literacy and health outcomes. And at the bottom of this slide are some fairly recent references, they're relevant references, that show us that people with low health literacy are more likely to need to go to the hospital, more likely to have chronic health issues that are poorly managed, they're less likely to go and seek treatment, and this is very costly. Low health literacy can add close to $238 billion of unnecessary costs to our already overburdened healthcare system. And all of you are expert healthcare providers from various walks of life. And all of you know what happens when patients fail to pick up their prescriptions or pick them up and take them wrong, or didn't understand that hypertension is a problem that needs to be treated over the long haul, not just for 1 month of their first prescription. All of these things result in people getting sicker and needing to get healthcare at a higher level. For example, in the emergency room or even in the ICU, when it could have, all these problems and complications could have been prevented if they simply understood or were able to access the health interventions that were being recommended to them. So here's a little bit more granular detail than that broad brushstroke I just gave you. This is from a study that was reported in the Journal of the American Medical Association just in 2017. And here we're looking at a patient population where they looked at whether the patient and the doctor or a care provider spoke the same language. LD means language discordant, LC means language concordant. And they were looking at people's glycemic control. So these are diabetics. And they looked at, in panel A, what percentage of the patients had a hemoglobin A1C less than 8%, which would be decent control. And in panel B, which percent of the population had poor control with a hemoglobin A1C greater than 9%. And in these groups, they had observed that there were changes in the assignment of a particular type of patient to a particular type of provider. And they learned that if a patient was language discordant, so look up at the A panel, a language discordant patient-doctor pair who then switched, so the patient now goes to, say it's a Spanish-speaking patient, and now they get assigned to a Spanish-speaking nurse practitioner. look what happens to the proportion of those patients who now achieve that favorable glycemic control, from 63% to almost 75%. So a dramatic increase. And then the bottom panel looks at people, fewer people having the bad outcome. And you can see that when you switch from language discordant to language concordant. So this is all, I think, in a way, almost a forehead slapper and a no-brainer. But we extrapolate from just if the provider is using language and words that their patient can understand, it's going to have measurable differences in their health outcomes. Now, all of this is taking place within an ecosystem. That graph I showed you in great detail is actually taking place in a small segment over here. See this box called healthcare services? Well, healthcare services are just one of many factors like housing, unemployment, water, sanitation, work environment, education, agriculture, and food production. These are all factors that are impacting on people's health, and that they in turn are going to be further influenced by social and community networks, individual lifestyle factors and choices that people are making about their health and their diet, and things that people can't choose, like the age or sex or constitutional factors about their bodies. So this is just to put into perspective how working on health literacy is a piece of a much more complex system in which our patients are living. And here's a conceptual drawing of the 4-level healthcare system that more or less accurately describes the world that we live in, with the patient at the center and their interactions between the patient and the care team. That, of course, is where we're focusing today, about the kind of communication that goes on between care team and patient. But the care team isn't in a vacuum, right? The care team exists within an organization of some kind that provides the infrastructure, and in which there are resources and there are other healthcare related things going on. And that organization, or those organizations themselves, exist within a larger environment that can affect things like people's transportation, insurance, healthcare purchasers. Where's the funding come from? What are the policies in a community that are going to impact on a person's ability to access and utilize the health services that we hope they have? So one targeted intervention at the level of health literacy and communication is a piece of a much larger complex whole, but it's an important piece. When we talk about health equity, this is a slide that I love to use. I think it's really important. And it illustrates that achieving equity requires an understanding of the root causes of disparate health outcomes. One size does not fit all when you're trying to help people attain their maximum achievable level of health. So in this picture, the apple is a metaphor for health and the best level of health that a person can attain. And if we make the same intervention for each individual person in our community, as you see on the left-hand side, where everybody is standing on the same size of block, some people are going to attain that apple and others will not even come close, even though we've allocated our resources equally between individuals. On the right-hand side, however, is a frame shift way of looking at that, is that we want everybody to reach the best apple that they can get. And if that's the outcome we want, it means that some people are going to need more blocks to stand on than others. And right-sizing those blocks, or giving the right kinds of blocks to the right person, is critical. And it's part of our job as we think about health literacy as one of our tools to achieve health equity. Here's a snapshot from much earlier in the COVID-19 pandemic. This was taken from the City of San Antonio's website, looking at Bexar County data. And the color coding here, actual numbers are not important to us, but those darker colored zip codes are areas where we see a higher impact of COVID-19, more cases reported and more bad outcomes related to cases of COVID-19. And later on, as we'll see in another slide soon, sometimes lower vaccination levels, at least early on in the pandemic. So we see enormously different health outcomes related to COVID-19, just as we have seen enormously different health outcomes by zip code in San Antonio for years and years and years, regardless of what parameter you look at. I mean, you could easily put this map up and say this is where the darker colors represent higher places where there are higher rates of diabetic amputation or higher rates of uncontrolled diabetes. So some of the same factors that take people down a path towards poor health outcomes from diabetes are going to be taking people down a path towards poor health outcomes related to COVID-19. And here is a graph that looks at the 22 targeted zip codes that our Health Confianza team is hoping to intervene with as we advance health literacy to enhance equitable community responses to COVID-19. You can see that we have 22 targeted zip codes. The actual zip codes are listed up on the right-hand side. It's a pretty large patient population that we're going after, almost 600,000 people. The color coding here tells us that the lighter the color, and this was from June 2021, the lighter the color of the zip code, the lower the proportion of people that had been vaccinated as of June 2021. Notice that there's a real disequilibrium. Where is the dark green? Dark green is way up north in San Antonio. As you go south and you look to the east and to the west, you see zip codes that have lower rates. Now, happily, we're already starting to impact these, and the colors are changing for the better, even after the last 6-7 months. But these disparities are what led us to zero in and try to focus in on these zip codes in particular. And many of the providers that are on this webinar are people who are caring for individuals that are in those zip codes. So what we are trying to do with the work that we're doing here today and overall is to implement a multi-level health literacy plan for San Antonio. We want to develop and disseminate information about how to prevent and how to mitigate the negative consequences of COVID-19. We want to promote and facilitate changes within our county health and social care systems. We want to improve health information, improve communication to promote informed decision-making as well as access to services. And we want to support and expand efforts to provide culturally and linguistically appropriate COVID-19 health information services in our marginalized communities. Please understand that we don't think we're only doing this for COVID-19. We think that all of these interventions are going to help us impact health equitable outcomes for San Antonio in the long haul. And so this is our model. And where we are today is you all are clinicians of one kind or another. You run a clinic, or you may be an LVN or an MA, you may be a physician. We've invited all of you. And we're talking about communication training here. And if we also have at the same time efforts going on where community health workers like Joaquin Abrego, who's joining us later today, at least I hope he is, and others who are interacting with the community on a neighborhood by neighborhood level, we are impacting clinician motivation as well as patient motivation to improve that communication, which improves the health literacy, which we've already defined, and that we hope will lead to patient engagement, meaning people adopting behaviors and accessing services that will improve their health outcomes. Here's an example of Health Confianza at work. This is during our pilot phase. We got out and around to places like Santa Fe Episcopal Church, which is in one of our targeted zip code areas. There was a food bank distribution going on there on a Saturday morning. So the Health Confianza team showed up at the food bank and talked to people. We had a big poster that had 5 plain language messages about COVID vaccinations, and this was being done in advance of what was to come later, which is the following week, a pop-up mobile vaccine clinic. So I'm going to read for you a couple of these messages because they exemplify one of those 6 communication skills that we're talking about, use of plain language. And so these simple messages are, you can help stop the pandemic by getting vaccinated. The vaccines are safe and effective. The vaccines are free. That might sound like a no-brainer, but we still find out that a lot of people don't really know that the vaccines are for free. Vaccines have side effects, yes, but these are normal signs that your body is building protection. So flipping something that people feel frightened about and think is negative into a positive. And then finally, you still need to wear a mask and practice social distancing after getting vaccinated. P.S. That might be getting updated soon as the CDC is about to give us new guidelines for masking, but we're not out of the woods yet, and masking is going to be with us for a long time. So the 5 key messages about COVID vaccine are an example of how to use plain language. This activity is an example of how Health Confianza is working on multiple levels, not just provider and patient communication, to promote health literacy in our community. And here are the 6 communication skills that we'll hear about at every Confianza session, and we'll start to unpack and develop these skills more specifically. They are setting the tone for communication, active listening, which means that you are responding to the patient as they're telling you something and asking questions that relate to something they just said that shows that you were actually hearing them, using plain language, acknowledging different perspectives. There's a lot of myths out there. We're going to talk about myth busting and how to do it well. It's so important that we don't shame people and we can acknowledge the different perspectives, even as we then bridge respectively from what the patient believes and which you know isn't true to the fact that you want them to take away and remember and utilize to inform their health decision. And then finally, using the teach back method to check for understanding. And in the course of our 7 sessions, you will have an opportunity to practice those skills. And the plain language, we're just going to unpack that one a little more detail here. This is a cartoon that shows the difference between using the term skin infection to talk to a patient rather than the medical term cellulitis, which when you say cellulitis, it's like you never said it, it falls flat. They spend a lot of their cognitive bandwidth trying to translate that. You waste time, you have to explain it again. If you train yourself to use the plain language up front, then the message is going to go through. So using plain language not only reduces time spent, it eliminates a lot of barriers, improves understanding, empowers people to act. Very basic.